Hello, everyone. Welcome to the first webinar of the WONCA Special Interest Group on Dermatology. I am Dr. Cheryl Chan, a GP from Hong Kong. I'm co-chairing the Special Interest Group on Dermatology together with Dr. Anneliese Willems from Melbourne. And I'm happy to be your host today. This is the first time we virtually gather together, so I'm so excited to see you all finally online after so many chats on the WhatsApp group. So feel free to take a moment to introduce yourself in the chat box and say hi and introduce yourself to other people. So before we begin, there are a few house rules that I want you to be aware of. Please keep your microphone on mute unless you're speaking. Use the chat to submit questions as we go, and we will answer the questions after the presentations. Given the size of our group, we will address questions at designated times during the session. This webinar is being recorded and will be shared with participants who cannot join today, and also it will be uploaded to YouTube later on. Please avoid sharing or taking pictures of any patient identifiable information or sensitive parts of patients. Okay, so now let's begin with our first speaker. Our topic today is from rashes to acne, addressing skin problems in primary care settings. So we will be presenting 3 cases. The first case will be presented by Dr. Willems. Dr. Anneliese Willems is a GP and senior lecturer in general practice at the University of Melbourne and co-chair of the WONCA Special Interest Group on Dermatology. She has authored over 30 peer-reviewed publications, and she is widely involved in dermatology education and research for general practitioners and medical students. Dr. Willems holds recognition of extended skills in dermatology through the Royal Australian College of General Practitioners and was a co-host of the dermatology education podcast, Spot Diagnosis. Today, she will be speaking on a case of persistent napkin dermatitis in an infant. Over to you, Anneliese.
Fantastic. Thank you so much for the introduction, Cheryl. Okay, so I'm excited to be presenting tonight for me on a case called More Than Just Nappy Rash. Before I launch into this case, though, I did just want to acknowledge, which is tradition in Australia, to acknowledge the traditional custodians of the land from which I am presenting today. Given I'm based in Melbourne, this is the Wurundjeri people of the Kulin Nation, and pay my respect to elders both past and present. This is a tradition with presenting from Australia.
Just to echo the comments in the chat, thank you so much for a wonderful presentation, Dr. Willems. So our next speaker is Dr. Cheryl Chan. Also, just another note, if let's say you do have any more questions for Dr. Willems, please place them in the chat so you don't forget them, and we will take note and hopefully come back to them at the end of the webinar. So without further ado, our next speaker is Dr. Cheryl Chan. Dr. Chan is a family medicine specialist in Hong Kong with a keen interest in dermatology and skin laser treatments. After completing her fellowship in family medicine from HKCFP and FRACGP, she also earned a master's degree in practical dermatology from Cardiff University. Dr. Chan currently serves as an honorary clinical tutor at the University of Hong Kong and has represented the young doctors movements at the WONCA executive. She's also one of our wonderful co-chairs alongside Dr. Willems. So today, Cheryl or Dr. Chan will be discussing acne vulgaris and rosacea in primary care. Over to you, Dr. Chan.
Thank you very much, Rochelle, for your kind introduction. Just a quick chat. Is my screen functioning well? everybody can see my screen well. Okay, so hello everyone. I'm Dr. Cheryl Chan. I'm a GP in Hong Kong and currently also the WONCA Young Doctors Movement Global Lead. I'm very happy to share with you my understanding of acne vulgaris and rosacea in primary care and hopefully presenting 2 cases with you. You're very welcome to jot down any comments and questions in the chat box. So first of all, I have no conflict of interest. My presentation is not sponsored today. And for acne vulgaris, it's actually very commonly seen in primary care. It is a chronic inflammatory skin disease of the pilosebaceous unit. We can see acne vulgaris almost across different ages, but predominantly it affects our adolescents and young adults. More than 20% of young people, they are affected by moderate to severe acne. And the pathogenesis, as all of you know, is very complex. It involves genetic, hormonal, microbial, and inflammatory factors. When we talk about acne vulgaris, it's very important that we align with some terminology. So when we see the whitehead, they are actually the closed comedones. The blackheads are the open comedones. And the papules are raised palm, which is less than 1 centimeter. For nodules, they are raised palm that is greater than 1 centimeter. And the pustules are filled with pus. For the pathogenesis, I always like to use an analogy of a triangle to my patient. I always tell them in the pathogenesis of acne, there is a triangle with 3 components. First of all, there is a follicular hyperkeratinization, and there is increased sebum production. With the increased sebum in production and also follicular hyperkeratinization, your sebaceous gland will get blocked. Once your follicles get blocked, you have a over-colonization of your bacteria. The C. acne, which is previously known as the P. acne, will have a inflammation of the follicle. That is all the beginning of the acne vulgaris. And it started with a folliculitis, grow into a papule, and then it gets inflamed, sometimes filled with pus and with more inflammation and become a pustule. So for the grading of acne severity, there are a few well-known grading systems. The global acne grading system was first introduced in 1997. It is a standardized objective method, and the severity score is based on lesion counts and the location. It gives a pretty comprehensive assessment. This is a diagram illustrating the global acne grading system. You can see there are different locations and each location will have a different factor, and you have to do a little bit of a calculation to calculate the final score. But in clinical practice, I usually use this CASS, which is the Comprehensive Acne Severity Scale score. To me, it is a more convenient score and it's very easily understandable. There is from grade 0 to grade 5, whether it's clear, almost clear, mild, moderate, severe, and very severe. It's describing the acne lesions, whether the clinician is being easily recognizing the nodules and also the comedones and papules, or where there is nodules and cysts and the area of involvement. So it is quite self-explanatory, and when I use it in my clinic, we can communicate easily with the other clinicians together with clinical pictures as well. So the role of C. acne, which is the Cutibacterium acnes, formerly known as the P. acne, there are recent studies showing that C. acne is not only a single homogeneous species, but comprises multiple strains with varying roles. The C. acne will stimulate the production of pro-inflammatory cytokines, including the interleukin-1 alpha and interleukin-8, contributing to acne lesion formation. And actually it forms a biofilms with the sebaceous follicles, and which then protect the bacteria from the antibiotics and immune responses. So these biofilm contribute to the antibiotic resistance. For the complications of acne, we know that acne is not only about the acute flare-up, but it brings long-term complication. And acne scars are notoriously difficult to treat. It can give you hypertrophic scar or atrophic scar. It can give you hyperpigmentation with all the dark spots and also the dark marks, especially in darker skin type, for example, the spectric skin type 3 or above, and it can cause a significant psychological distress to our patient. We are all family doctors after all, so we know that biopsychosocial access is very important when we treat any kind of illness. When we treat patients with acne vulgaris, it is very important that we take into account their emotional well-being and how the acne is affecting their social ability, their psychological health, and we can see that the quality of life for people with acne and for people with other severe like other chronic illnesses such as asthma and epilepsy, you can see that the physical impact might be less, but the social impact and the emotional impact is very huge. So I would like to present you the case one. This is a 22-year-old female who works as a graphic designer. She comes to my clinic and complains of multiple papules and nodules over mainly the forehead and bilateral lower cheek for 6 months. On physical examination, we can see multiple comedones and cystic nodules. The acne lesion severely affects her mood and quality of life. It brings her low self-esteem and she avoided social activities. If we look at the CASS score, I would say it is at least a moderate to severe acne vulgaris because you can see more than half of the affected area is involved, and there are numerous comedones, papules, and pustules that you can see. There are also a few nodules and cysts. When we continue with the history taking, she has not been taking any new topical agents. She has regular monthly cycle and she has no other signs or symptoms of PCOS. She has seen a GP before and tried a course of oral doxycycline 100 milligram daily for a month already, but she is not seeing any improvement. So she came to my clinic to seek for help. So for general advice for acne vulgaris, we would advise her to have gentle cleansing twice daily. Avoid picking the lesions because it will give you the atrophic scar. We need to use non-comedogenic skincare and cosmetic products. We need to educate the patient about the chronic nature of acne and set a realistic expectations. And even in these cases, I would discuss about potential complications such as the atrophic scar. There are recent studies showing that a low glycemic index diet will be helpful in reducing the sebum production and also in acne vulgaris. So we advise her to take a low GI diet. For the first-line treatment, for mild to moderate acne, we recommend topical treatments such as benzoyl peroxide, which gives you an antibacterial and anti-inflammatory property, topical antibiotics such as clindamycin and erythromycin, which is dealing with the overproduction of C. acne. Topical retinoids such as adapalene, tretinoin, and the third-generation retinoid tazarotene, which normalize the follicular keratinization. If you remember the triangle of acne, so we are trying to tackle different parts of the pathogenesis of acne. Salicylic acid is a common keratolytic agent found in a lot of face wash and in our chemical peels that helps unclog the pores and reduce inflammation. Sometimes we would use combined topical agents such as benzoyl peroxide together with topical antibiotics or benzoyl peroxide together with retinoid. They are available in different brands. For systemic treatment, if the topical treatment does not show in good enough response, we would consider systemic treatment, such as oral antibiotics, like minocycline, doxycycline, or tetracycline. We can consider hormonal agent for female, especially if they have contraceptive need. And also our second-line treatment will be isotretinoin for severe nodulocystic or resistant acne, and the result is quite promising. For oral isotretinoin, common brand names include Accutane, Roaccutane, Oratane. The initial doses would be a 0.3 to 0.5 milligram per kg per day. Usually, nowadays, we advocate for a low-dose approach for oral isotretinoic acid and try to use the lowest possible dose, lowest effective dose in treating it. For maintenance dose, typically is 0.5 to 1 milligram per kg per day, and it is titrated based on the response and tolerability and side effects of the treatment. Duration usually lasts for around 16 to 20 weeks, aiming for a cumulative dose of 120 to 150 milligram per kg in order to achieve a better remission and reduce relapse. Common side effects include dry lip, flare-up of eczema because the skin gets dry, deranged liver function, joint pain, muscle pain, elevated triglyceride, and mood swing. It is very important that we check the urine pregnancy test before prescribing. And in my practice, I would monitor the fasting lipid and liver function test at least before starting the treatment and 1 month after the treatment. In the USA, there is an iPledge system, which is a risk management program mandated by the US FDA before you prescribe or during you prescribe isotretinoin. This is a project designed to prevent pregnancy-related teratogenic effects associated with isotretinoin use. Because we know that the most severe side effect of isotretinoin is a teratogenicity in the fetus. So in my practice, I would sign a consent form with my patients, and also I would advise them to use a reliable form of contraceptive. For Miss K, this young lady, for the hyperkeratinization in the follicles, I prescribed her a glycolic acid and salicylic acid 10% face wash to be used twice a week. She came to our clinic once monthly for a chemical peel. The peel we use is a 40% mandelic acid peel. For the component of the acne, we gave a topical duet cream, which include a clindamycin gel and also a benzoyl peroxide twice daily to large papules and nodules. A practical tips is that when you apply this kind of benzoyl peroxide cream, it will get quite dry and irritative. So I try to ask her to use a cotton bud and just apply a small amount on top of the papule. We prescribed all isotretinoin acid for her, and based on her body weight, on calculation we started her on 15 milligram per day. And also we gave her oral probiotics and omega-3 supplements. For the progress after 4 months later, you can see a significant reduce in erythema, nodules, and papules of the acne lesions. And there is a 80 to 90% improvement in the lesions, and she's quite happy with the results. However, there are some residual atrophic scars that we can see. For atrophic scars, there are different types of acne atrophic scars, namely the ice prick scar, which is most difficult to treat. It is a deep dermal scar. Sometimes we need to even have a punch excision of the ice prick scar. We can have rolling scar, box scar, or sometimes we can have hypertrophic scar. I will not go too deep into laser treatment for hypertrophic or acne scar today, but there are available fractional lasers such as 1927 fractional laser, pico laser with micro lens array lens, and fractional CO2 lasers. And since I talk about probiotics, and this is a emerging area of active research in dermatology, there is some small clinical trials and reviews suggest that there are modest benefits, such as reducing lesion counts and inflammations. However, the results are quite inconsistent. So we will not recommend probiotics as a monotherapy. We need larger and higher quality RCT studies to suggest for stronger evidence. But currently, I'm using it as an adjunctive therapy in our patients. if we talk about the probiotics, we are talking about gut-skin axis, and nowadays the brain-gut-skin axis. This is the bidirectional relationship between the gut microbiome and skin health, because both the skin and guts are protecting our body from the outside bacteria, and the microbiome is a key regulator for the immune system. It aims to maintain homeostasis. Hence, if we have a dysbiosis in the skin or the gut microbiome, we will have an altered immune response. And it is suggested that this dysbiosis will be related to multiple skin diseases such as atopic eczema, psoriasis, acne vulgaris, or even in skin cancer. So we also know that emotion matters as well, because stress can give us dysbiosis and also worsen the condition of acne. So the second topic today is rosacea. Rosacea is a chronic inflammatory skin dermatosis. It's characterized by episodes of flushing. You'll see facial redness, persistent redness, hotness, sometimes with visible blood vessels or papules. Rosacea affects about 5 to 10% of adults worldwide, but it's more commonly in women and it's more commonly in fair-skinned individuals. The age of onset is usually in middle age, around after 30 years of age. And the exact cause of rosacea is actually still unknown nowadays, but we know that it is a multifactorial process. There is genetic predisposition, vascular abnormalities such as the vasodilatation, immune system dysregulation. There is a role of Demodex mites, which I will talk about more, and there is neurovascular dysregulation. Common triggers of rosacea include sun exposure, spicy food, hot pot, especially in China. We love to have hot pot all the time, even in summertime. Alcohol drinking, stress, exposure to heat, such as when you go to the Japan and then you have an onsen, you have a flare-up of rosacea. And there are some studies showing that even hairspray will exacerbate the episodes of rosacea. Rosacea primarily affects the central face, so there is a central distribution. You will see the lesions in cheeks, nose, chin, and forehead. It is not acne, but it can resemble acne. It is characterized by episodes of flushing, persistent redness, and with visible blood vessels and telangiectasia. Sometimes we have a diagnostic challenge when you are seeing a kind of what we call the rosacea acne, or sometimes people come with nodular eruptions over the face. You don't know whether it's acne or rosacea. Here is a diagram which differentiates acne and rosacea. In my clinical practice, I find a few useful tips. First of all, I'll look at the site of distribution of the lesion. For acne vulgaris, it usually affects more peripheral areas in the cheek and also in the jawline areas. For rosacea, it will be more a central distribution. Second, I'll look carefully whether there are any comedones, whether there are white heads and black heads. In acne, you will see a lot of white heads and black heads, but in rosacea, you only see the papules and nodules without seeing the black heads. And thirdly, I'll look at whether there is any facial abnormality. In rosacea, you'll see more erythema, more telangiectasia, and more vasodilatation. And together with, sometimes we can see some complications such as ocular rosacea or even rhinophyma. But rhinophyma, having said that, it is quite rare in my locality, so I have not seen a case of rhinophyma yet in my practice. So what is the role of Demodex mite? There are studies who show that individuals with rosacea often have a higher density of Demodex mites on their facial skin compared to healthy controls. That's why there is a role of antiparasitic cream such as ivermectin cream nowadays in the treatment of rosacea. For the classification of rosacea, there was a classical 4 subtype classification in the past, namely erythematotelangiectatic, papulopustular, phimosis, and ocular. However, nowadays, we are shifting to a more phenotypical classification because we can see that in some patients, there are an overlap of symptoms, and it is not so clear-cut that they can be categorized into the 4 subtypes. Some patients, they have multiple phenotypes simultaneously, so there are overlaps. In the new classification developed in 2017, the main phenotypes include erythema, telangiectasia, papules, pustules, phimosis changes, and ocular rosacea. So it became a more kind of a descriptive classification. We can describe patient having a rosacea with erythema over bilateral medial cheeks with papules, or we can say there's a rosacea with erythema, papule, and phimosis changes. So my second case is a 35-year-old lady, office lady. She presented with persistent facial flushing with papular eruption for more than 1 year, which has a very clear trigger. It was triggered by spicy foods and heat. On physical examination, there is diffuse facial erythema. On this diagram, you can clearly see her telangiectasia, mainly over the cheeks area and around the nasal areas. And on closer look, there are no comedones, but a lot of facial vascular abnormalities. For the treatment algorithm for rosacea, first of all, we have to focus on general measures such as the trigger avoidance, cold compresses. We need to have gentle skincare, avoid using abrasive skin wash, and sun protection is very, very important. For the treatment strategies, it is since we are shifting to the phenotypic classification, so the treatment strategies is also based on which phenotype patient is presenting with. If patient is mainly presenting with telangiectasia, so the first line therapy would be a intense pulsed light or long pulse vascular laser. If patient is mainly presenting with erythema, then we can consider using laser treatment therapy and also topical therapy such as brimonidine. Brimonidine is a topical vasoconstrictor. It gives a very quick relief. However, if we use it in a chronic term, it will cause flare-up of the rosacea. So I usually reserve it to the patient, and also I would ask them only use it when you really need to have like a short-term relief for a few hours, because the half-life is very short and you will have a rebound after 5 to 6 hours. Sometimes we can prescribe oral antibiotics as well to reduce the inflammation, such as oral tetracycline or oral doxycycline. And oral isotretinoin is quite reserved as a second-line therapy. For papules and pustules, we would use oral antibiotics earlier as a mainstay of treatment, such as tetracycline or doxycycline. So this topical metronidazole gel is available in 0.75% or in 1%. It is marketed as Rosacea, and it has both inflammatory and antimicrobial properties. We would use it as first line for the inflammatory lesions and for the erythema. It can be applied once daily or twice daily. For topical ivermectin 1% cream, which is marketed as Solantra, it is applied once daily. It has antiparasitic and anti-inflammatory properties, and it is effective for papulopustular rosacea, and the main mechanism of action is to reduce the dermodes concentration. For long pulse vascular laser, the laser I use is a ND-YAG laser. It has different wavelengths such as 532 and 1064. The 532 wavelength targeted specifically on the blood vessels, and patients came to our clinic to receive treatment every 4 weeks. For the progress, before the treatment, you can see on the right-hand side, it is before laser treatment. So after 3 months of laser treatment, you can see there is a significant decrease in telangiectasia and decrease in erythema. And also there is reduction in the papules, papular eruption. So here are my references today. This is the end of my presentation, but I would like to welcome you all to the WONCA Asia Pacific Regional Conference in Hong Kong 2 years later. Thank you.
Fantastic. Thank you so much for your presentation, Cheryl. It's interesting. I've worked in this area for quite a while, and there was definitely a few things I learned there and some really good reminders as well for my own practice. I'm just wondering if we have any questions at this point. I think it's a really interesting question about the prescribing of isotretinoin. I know there's a lot of variation from country to country with that, and in Australia we have some restrictions against prescribing it. Having said that, there may be some changes happening there. Watch this space. We've got no questions coming through at the moment, so I might move on to our final speaker for this evening. I know that we're just getting slides ready to go. Okay, so our last speaker is Dr. Rochelle Uy-Hicks. Rochelle is a specialist general practitioner with a special interest in dermatology, skin cancer, women's health, and medical education. She is passionate about educating patients and the next generation of doctors, as seen by her involvement with the Royal Australian College of General Practitioners and her previous role as a co-joint associate lecturer at UNSW. Dr. Rochelle advocates for improving access and health outcomes for rural and regional Australians. She currently works as a clinician at Pinnacle Dermatology and is involved in clinical research with the University of Sydney and the Kids Research Institute in Western Australia. Today, she will share a special case entitled, "Is It Just a Spider Bite?" Over to you, Rochelle.
Thanks for the very warm welcome, Dr. Willems. So I'll try to move quite quickly because I understand that we're running a little bit short on time. Now I'm just trying to see, sorry, I think I'm having a similar issue to Anneliese when I couldn't click my slides forward. So basically just no conflict of interest to declare. Most of my advisory roles are to do with respiratory syncytial virus and immunizations. Just a little bit of background as to where I'm based. Similarly to Anneliese, I am from Australia and from New South Wales. And just so that people can actually recognize, I guess, where I'm actually from, it's in a town called Orange. And I know that I've got another doctor here who's on the Zoom as well. So thank you for joining us. But basically in Australia, there is a bit of a shortage of dermatologists, which is probably in a number of other countries as well. So we have 660 dermatologists for Australia, and in the region that I live in, we have one local dermatologist for our region. And this is the area that we service in our clinic. So for that one local dermatologist and myself as the GP alongside her, and our clinic caters to a population of approximately 30,000 people, which may not be a huge amount in the grand scheme of things because there is, I guess, a shortage in the rest of the world as well. So moving on to the case, this was a referral letter that I received from the patient's regular GP, just wanting a second opinion regarding some lesions on the bilateral shin and forearm. GP was querying whether there might be some arterial insufficiency or vasculitis, and the patient was commenced on antibiotics already. So a little bit more detail, the patient is a 70-year-old female, and she's actually awaiting a left posterior tibialis tendon reconstruction in 2 weeks' time with one of our local orthopedic surgeons. But unfortunately, the surgeon was unwilling to proceed until the skin condition had been appropriately managed. So In the interest of time, this was meant to be slightly more interactive, but even if you want to just pop things into the chat box just so that you can start thinking about what you would ask, just want to ask, I guess, what further history you would be taking, but I'll move on for the sake of time. Oh, sorry. So wanted to find out a bit more about the presenting complaint. So the patient was very fixed on the idea that she had a white tail spider bite on the right anterior shin 4 weeks ago. And she kept stating that it was the spider bite that had triggered everything. The rash had developed after that, according to the patient, and was very itchy. This is her past medical history, so does have quite a few medical conditions, and there is quite a strong family history of atopic eczema or dermatitis. Patient was on oroxine, vitamin B12, and vitamin C. And this patient actually did say that she had multiple allergies. She was apparently allergic to all corticosteroids and honey, penicillin, cephalosporins, and morphine. My boss did want me to highlight to everyone today that being allergic to corticosteroids is a little bit of a red flag for us because it's almost impossible for a patient to be allergic to corticosteroids, given that our body produces them naturally, and that it could actually just be one of the added ingredients in corticosteroids. So on examination, this is what I saw. And I'd love it if people could just also have a bit of a think about how would they describe these lesions if, let's say, you were needing to speak to another clinician or speak to the dermatologist that you refer to, or if even just for your clinical notes. So great if people can just jot a couple of ideas into the chat. So how I would describe it is that on the anterior lower limbs, there are widespread erythematous lichenified lesions with multiple crusted and weeping excoriations. There are also multiple erythematous nodules. This is the location that the patient kept stating was where the spider bite occurred. It's also very important to note that sometimes it's helpful to use severity scales when assessing someone's eczema. So you can look at things like body surface area that's impacted or affected, as well as use an index like the eczema area and severity index, otherwise shortened to EASY. I think at some stage there's also a lot of total body photography being used, particularly in Australia, and some clinics are actually using them to help assess and monitor progress of things like eczema and psoriasis. So I wanted to just talk about spider bites briefly because probably in Australia, maybe not so common in other countries. But in Australia, we have the white tail spider, which is commonly found in the Australian bush and urban environments. And just so that everyone's aware, most bites usually result in just mild symptoms similar to those of a bee sting. So you might have some immediate burning sensation in the affected area, followed by some mild swelling and an itchy red mark that generally resolves within 24 hours. Obviously, there would be rarer, more severe cases where there might be severe pain or discomfort at the bite site, and someone might develop nausea, vomiting, headache, or a general feeling of unwellness. But it doesn't really fit her examination findings. So I was just wondering whether this could be more than a spider bite. So again, love you all to think about what your top 3 differential diagnoses are. Is anyone brave enough just to pop anything in the chat? I'll keep having a look at the chat box. Great. Thank you so much, Dr. Anneliese. Yes, atopic dermatitis is definitely up there. Dr. Chan, yep, drug eruptions, wonderful. Excellent. So, oh, sorry, skip through. So my provisional diagnosis was infected venous or discoid eczema with prurigo nodules, and that possibly there was an exacerbation due to itch from the spider bite. Other differentials, allergic reaction, actinic prurigo, lichen simplex chronicus, impetigo, psoriasis, venous insufficiency, or lipodermatosclerosis or arterial insufficiency, and definitely have to add in the drug eruptions from Dr. Chan. So in terms of investigations, fortunately, her regular GP had already done a swab, which was very helpful, and it showed a really heavy growth of Staph aureus, and it was sensitive to a number of antibiotics. Unfortunately, as we saw, the patient had stated that she had some renal and hepatic impairment, and she was quite hesitant and reluctant to being put on antibiotics. So her GP had started her on clindamycin, and she had also said that she was allergic to penicillins. And so I chased some of her recent blood tests to ensure, I guess, the level of renal and hepatic impairment. And given her hesitancy in changing antibiotics, we just continued the clindamycin as it didn't look to be overly infected. On the referral letter, her GP had suggested that we do a biopsy, but at this stage, we didn't think that was necessary because it did fit with infected eczema at this stage. So just having a bit of think, what would you do to manage this lady? So there's, I guess, a number of different things that you would do to treat contact dermatitis or atopic or infective eczema. Oh, sorry, I was just reading Dr. Rahman's comment. So it'd be great if people could just pop in a couple of ideas that they would normally do in their general management of a case like this. So I guess in terms of management, it can be really important to assess a patient's quality of life and how much it's been affected by eczema, particularly as severe eczema can affect things like sleep, and for children can particularly impact learning and development. Sometimes it can be helpful to do a quality of life index or survey, and that could be something like the DLQI. Yes, great. Dr. Lim has mentioned giving a topical steroid, which we're going to get to very shortly. I love to break things into sort of steps within management. So I guess one of the big things is patient education. So explaining to the patient, I guess, the condition that they've been diagnosed with, so the atopic dermatitis and eczema, as well as that there is an element of infection. And potentially reassuring the patient that the spider bite could have contributed to the itch that she's experiencing, but that the trigger is not really persisting anymore. Other investigations that we could do include lower limb Doppler ultrasounds if you felt that was relevant. And I do like to break things into non-pharmacological and pharmacological. So really important, I guess, with eczema to try and maintain the skin barrier as much as possible. And the ways that we can do that is avoiding any trauma or scratching or irritation, avoiding exacerbating factors that can contribute and trigger flare-ups. So hot showers, chlorine sand, soap, bubble bath, and ensuring that we do use emollients and moisturizer. Other things that we can use at our disposal are cool compresses, compression stockings, and elevation, and that can help stop people from scratching and itching, and bleach bars, as Dr. Anneliese also mentioned earlier. In terms of pharmacological, a couple of people have mentioned topical steroids, and I guess looking at different types of steroid creams and which ones we should use. So that's an excellent question, and we're going to get to that really shortly, as well as when to give oral corticosteroids and antibiotics. So in this case, for this lady, we commenced her on betamethasone dipropionate, which is quite a moderate potent corticosteroid cream, and given just the extent of the lichenification, we used that. Given that she was very hesitant to using corticosteroids, we thought an ointment would be better for her, and have less things that could cause stinging and irritation. It did take us a while to convince her, and we're going to talk about steroid phobia shortly. Dr. Gooden has asked about sort of when to give oral corticosteroids and antibiotics. And I guess it depends on the severity and the degree of involvement. So I guess if you're looking at large body surface areas, that's probably when you would start considering giving an oral corticosteroid, or if they're really erythrodermic, so like red all over, that's kind of a good starting point, or even just to get things under control. And we've got some really good algorithms and flowcharts, which I'll direct you to shortly. In terms of use of oral antibiotics, definitely in this case, we'd grown some bacteria, and there was an element of infection. I think if you can see that the lesions are weeping and there's signs of infection, that's when it'd be helpful to use an oral antibiotic. Okay, lots of good questions. Hopefully I'll answer them as we go along. So this is also a really good resource to give to patients. She was sent away with an eczema action plan, and I've included the link where you can find that if that's helpful for you to provide to your patients. It's often very helpful because patients can get overloaded and overwhelmed with the amount of information we give them. And it's got a bit of a stepwise approach for if someone has a flare-up, you know, which cream to use and how much and how many times a day, whether or not to use things like bleach baths, whether to use compresses or wet wraps. So this is very helpful to send away with your patients, and also make sure you scan a copy into your own records in case the patient loses it. In terms of bleach baths, so Dr. Umu has asked, and that's a great question, can be very helpful to sort of decolonize the skin. So definitely something that we do recommend. And this is just a little, I guess, diagram explaining it. And there are some really good instructional videos that you can find as well. So a half cup of just your standard like White King's bleach for a full tub, or a quarter cup. And then you can, for children, use 12 mils or a teaspoon per 10-litre bucket. So in terms of management, it's really important to ensure that we regularly review the patient. It's recommended in the guidelines now to look at sort of 2 to 4 week reviews, and that's really important to actually monitor a patient's compliance. In terms of this patient in particular, she actually was located about 125 kilometres away from where I practice. And so throughout the course of looking after her, I received multiple phone calls and emails from the patient. So similar to, I guess, some of the challenges that Dr. Anneliese faced in terms of having to do telehealth and diagnose things over the phone. But the patient was quite adamant that there was increasing pain over the site of the original spider bite, that there was increasing redness, swelling and crusting. And when she was asked to present for a review and a potential biopsy, because she said that the GP recommended one, she was unable to attend. So at this stage, we advised her to present to the local hospital emergency department if she had worsening symptoms. So it's really important as patients' GPs or the doctors looking after their dermatological concerns to actually manage expectations and beliefs. So for this patient, she did want a bit of a quick fix, and didn't necessarily want to use the recommended treatments. But that's where education is really important, to explain that it is a chronic condition and that we want to be able to manage and reduce the number of flare-ups. As I mentioned, the regular GP was suggesting via the patient that we do a biopsy, but we still didn't feel that there was any indication. And for us, it was very important to regularly communicate between the GP as well as the orthopedic surgeon, because they had pushed back the date of her operation. And of course, regularly reiterating the plan to the patient. So this is when she came back about 4 weeks later. And unfortunately, it's not completely fixed. And I guess had some questions about why we hadn't achieved our end goal yet. So it's very important to check with the patient whether they're being compliant with the plan and don't assume. So she explained to me that she was actually only using the topical corticosteroid for 1 to 2 days until it became red and itchy, and then she would stop. And she was using Vaseline as moisturizer as she'd had an allergic reaction to the Dermis ointment, which is quite rare in our understanding, but the patient wasn't able to tolerate it, and she'd been spending some time in the sun to help heal her eczema. She denied scratching her legs, but whilst she was sitting in my room, she was vigorously rubbing her legs with her hand. And so it's really important, I guess, to be able to observe what's going on. And on further questioning, she did say that she was giving her legs a really good wash with a face washer, and she was actually scrubbing her legs. And so you can see that in that there were still quite a few excoriations. So again, making sure to reiterate the plan and offer biopsy. Then the patient was offered a biopsy, but she actually declined, and she decided to give it a further 2 weeks, and said that she would be compliant with the plan. And this was 2 weeks later. So massive improvement. And so we felt that it was a success. And so she was discharged back to her regular GP. And we gave her a bit of a plan for flare-ups and weaning topical corticosteroids. The patient also finally had her ankle operation on the 5th of June. So that was a bit of a win. Now, this is just, I touched on it briefly, that we've got a really good eczema management algorithm now. Sorry, the actual... I might have to update the link here. I've got the wrong link, but this is an eczema management algorithm that our own Dr. Anneliese has contributed to. And so this is really helpful, just as a bit of a guide as to how we should actually be using topical corticosteroids, and when to apply them and when to sort of escalate as well. So I guess there are quite a few principles. I think Dr. Mohammed, yes, it could be a papular urticaria. I think it probably isn't classic, but it's a good differential to consider as well. In terms of principles of prescribing topical corticosteroids, very important to actually inquire about a patient's views. Now, I do note that we are very much running out of time. So I'm happy for people to get a copy of my slides, but you want to kind of consider an appropriate strength of topical corticosteroid for the type of skin that you're treating and the severity of disease. And often we want to taper and ensure that we can bring about remission if possible. And we don't necessarily have to use only mild corticosteroids in babies and young children. So this everyone can review in their own time. Happy to share my slides, but this can also be found online. But these are the 5 potency classes of steroids that we have in Australia, and these are the brand names that we have. We talk about fingertip units, and so that's actually helpful when we're thinking about how much we need to prescribe to the patient. And these are just some basic calculations to work out how many tubes we should be providing. Under the PBS here in Australia, we can often provide more tubes depending on the percentage of body surface that's involved. So these are just some of my tips and tricks, but feel free to have a read through. But did want to just very briefly talk about steroid phobia. So topical corticosteroids have been used since the 50s, and we do recommend that we use them to manage active atopic eczema in combination with the regular use of emollients. However, patients are often concerned about the adverse effects, and steroid phobia often leads to undertreatment and complications. So these are some of the local and systemic adverse effects that we see with topical corticosteroids. It is very important to note that it's rare when used appropriately and as per guidelines. So we definitely recommend having a read through those guidelines, and I'll make sure that I post the correct link. And maybe Dr. Anneliese might be able to post it in the chat group now. Basically, the benefits do outweigh the uncommon adverse effects. So risk of excoriation, infection, impact on sleep and learning and development in children. So many of you would have probably seen photos like these, especially on TikTok and social media. Topical steroid withdrawal is a very controversial topic, and we do need to talk about it. Unfortunately, there are many doctors and dermatologists who deny that it happens, which in itself is an issue and often gets patients offside. It can happen, but it is rare, and most flares are due to inadequate treatment of severe eczema. And there's sometimes a bit of a challenge in determining if it's due to the cessation of topical corticosteroids or it's due to worsening of the underlying skin disorder for which the steroids were prescribed. This is just a little bit about topical steroid withdrawal. I think, unfortunately, just due to time, it's probably best to go through them in your own time or if we have questions. But one of the things to note is that fluorinated corticosteroids do definitely increase the risk of topical steroid withdrawal and using topical corticosteroids on thin skin. That's just another management flowchart that's from the Australasian College of Dermatologists. How are we going for time, Cheryl and Anneliese?
We
I
are
think
getting a little bit tight with time. I'm wondering if maybe we could kind of wrap up in the next minute or two, and then we can.
Yep. I'm on my take-home point slide. Great. Take-home points, I guess, was this really just a spider bite? Really important to take a good history, like Dr. Anneliese also mentioned, and to examine the patient because that can give us a lot of information. Just a little quick note about delusions of parasitosis. So we don't actually really know whether or not this patient did have a spider bite, and she was quite fixed on the idea that she did, and that was the cause of all of her symptoms. But she does have a strong history of atopic eczema and dermatitis. So I guess it's just something to be aware of, is that can be a condition where a person has a fixed, firm, but erroneous belief that they're infested. And it can be primary or secondary, so it can be related to other conditions like dementia, depression, or an underlying medical condition. More common in women, so 2 to 1, and often presents in the late 50s and early 60s, and is associated with some complications. And just highlighting, I guess, in here, really important to ensure that the patient is compliant, that we actually listen and understand their concerns, particularly with any of the management options that we're offering, and to educate the patient. And of course, set realistic expectations and make sure that they do use their emollients or moisturizer for maintenance and topical corticosteroids for flares. Great. Sorry that we didn't really have much time for questions, but I'll hand back to Dr. Chan and to Dr. Willems.
Thank you so much, Dr. Rochelle Hoyks, for the wonderful presentation. I do notice that there are a few questions in the Q&A section. Do you want to answer like 1 to 2 quickly?
Yes. I kind of tried to answer them throughout. Are there any that... yes. There's a question from Dr. Ron from the Philippines. So given the patient's reported steroid allergy, would it be appropriate to consider alternatives such as calcineurin inhibitors in cases of steroid phobia or hesitancy? Yeah, that's a really great question. And we definitely do have these up our sleeve. So thank you for mentioning them. I think in the initial stages of inflammation, and Dr. Anneliese can jump in as well because she has a lot of experience in this field, and I'm sure Dr. Chan does as well. But often for the initial inflammation stage, it's really helpful to use a topical corticosteroid. And then sometimes in the maintenance, that's when we can switch them over to something like a calcineurin inhibitor. For, I guess, face, I think often we would probably tend towards using topical corticosteroids just for a couple of days to get inflammation under control, and then switch over a lot faster to something like pimecrolimus or tacrolimus. So yeah, definitely a good question, and it is very safe as well as an option. I guess there is some suggestion that it might increase risk of developing skin cancers. But if, let's say, we're using on areas that aren't classically exposed to UV radiation, then we're quite comfortable. Anything else to add from you, ladies?
I was just going to say one of the barriers I come into is often pimecrolimus just isn't quite strong enough compared to tacrolimus. However, tacrolimus, both of them can burn and sting when you're using it, and often there's a few barriers with use as well. Also in Australia, tacrolimus has to be compounded. I'm aware that it's available quite conveniently in some other countries. So that's a frustration we have with our practice here. I'll stop talking though, because I know that we have run over time.
All right. So thank you very much, everyone, for your attending. I know it's a Sunday and it's supposed to be a family time, but thank you so much for making the effort. And I hope all of you have some take-home messages. And thank you once again to all of our speakers today for all of the wonderful preparation and presentation. We would like to kindly ask you to switch on your camera for a photo taking session together, and I will post it in the WhatsApp group later. So if you don't mind, please switch on your camera, and on the count of 3, we will take a group picture together. Unfortunately, there is no certificate after the discussion because it's not a certificate course. It's more like a case sharing webinar. And it takes quite a lot of secretariat support if we need to issue certificates. At the same time, we don't have the manpower to do so. All right, so is anyone joining the picture, or it's just 3 of us?
It's just the 3 of us.
We've got Dr. Mohammed, who's turned on his screen, I think. Or maybe it's a photo.
Oh, the video's locked.
Oh, the video is locked. Oh, sorry. Start video. Okay. Here you go.
Thank you.
I do recognize some familiar faces. Hi, Riza.
It's so nice to see people's faces.
Yes.
Hi. I always see the WhatsApp, but never seen it in person. I'm Umu from Malaysia.
Hi,
Yes, hi.
Thank you so much for linking us with your webinar before. It was very informative.
Oh, thank you. Thank
I
you for
learned a lot. I learned a lot from Dr. Jason.
Yeah.
I
That's
just
good.
realized I didn't allow video video showing.
It's okay.
I'm so sorry for that. All right, okay.
Fantastic.
So, fantastic. I'm seeing more and more
Peter,
people
you
join.
can get in the photo.
Okay. So on the count of three,
Can you see?
on the count of three, 1, 2, 3. 1, 2, 3. One more time. 1, 2, 3. Cheers. Thank you so much for joining today and see you around soon. See you online. See you in Lisbon.
Thank
I
you
would
very
just
much for the
everyone.
good talks.
And if anyone's ever interested in contributing to our next webinar, we would love to have greater representation from other parts of the world as well. It was a bit Australia-centric today. We would be here to help bring the cases to life if any support was needed. So we'll be in the background helping. But thank you so much for attending.
Thank you and stay in touch. Bye.
See you. Bye.